we were always laughing at female patients. And when this woman, when she got angry at me, I realized that I couldn't work for the rest of my career having no answers for all the symptoms and complaints that women had. So it was a shock. I realized I have to do something because otherwise I can't do my job properly.
What helped you then to see that you were actually in a system that wasn't seeing or couldn't see women? For decades, cardiology was built on one template, the male body as the model for disease. But in 1991, a single patient shattered that illusion, and a young Dutch cardiologist realized the system she trained in could not see half the population. This is Professor Angela Maas, clinical cardiologist of 35 years, founder of Europe's first outpatient clinic for women, professor of cardiology for women at Radboud University, recipient of national and royal honors, and the Netherlands' first representative to the United Nations. She's a pioneer who has spent her career asking a simple, radical question. What if the problem isn't the women, but the way medicine was built?
So in the beginning, they thought I believed in fairy tales, that I was discriminating men and women. And, you know, those boys, they told me, I don't discriminate. For me, women are equal. But now we know, 35 years later, we know that we have to discriminate because there is a difference. And if we don't make that difference, we misunderstand many of our patients.
In this episode, you'll learn how Angela uncovered the hidden patterns of women's heart disease, why pregnancy complications reveal the cardiovascular future, how menopause reshapes the microvessels, and why ignoring sex differences isn't equality, but misdiagnosis.
If you look at women starting menopause at the age of 50, and you look at them 15 years later, they will have stiffened vessels and a lot of condition and a lot of symptoms. So that means that prevention of their risk factors needs to start early. We have to start at the beginning of menopause transition.
I'm Maryann Self. This is Blindspot Capital. Let's talk about the moment one doctor realized women were never the problem, but the model was. Some investments chase returns, others shift reality. Welcome to Blindspot Capital, the show where we trace the capital flows, structural decisions, and invisible forces shaping the future of health. Angela, I want to start where your story really begins. You've written about that moment in the early 90s, a patient in tears saying to you, why don't you explain my complaints? Why can't you explain my complaints? What did that moment do to you?
Well, it was a bit of a shock. And I was a cardiologist, a young cardiologist since 3 years. I became a cardiologist in 1988. And I've been raised along the standard of the white male patient. And, we were always laughing at female patients. And when this woman, when she got angry at me, I realized that I couldn't work for the rest of my career having no answers for all the symptoms and complaints that women had. So it was a shock. I realized I have to do something because otherwise I can't do my job properly. So in this moment when a patient got angry at me in 91 was a bit at the same time that the first publications came in the big medical journals about sex and gender differences in myocardial infarctions, in risk factors, etc. So it started almost 35 years ago, and it was a wake-up call, what this woman did to me. She said, you have to go into this field because you're not doing your work properly. And I realized that I had to do something.
Wow. So I think my next question would be then, when you read that journal, you've had this experience with this woman, and you've kind of had this awakening. What helped you then to see that you were actually in a system that wasn't seeing or couldn't see women?
Well, I think from that moment, I started to read everything in the journals that I could get on the subject of sex and gender differences. But also, I looked around if there were networks, if there were books. And I was lucky in 97, so that's 6 years later, that a big worldwide study, the Ruth trial, also passed by in the Netherlands. And I was asked, a good friend of mine, a cardiologist, he asked me, do you want to be the principal investigator in the Netherlands? And I said, yes, of course. And for me, this was the opportunity. And at the time, at the beginning of this century, internet came up. It was also for me an opportunity to work on a PhD thesis on the subject. And I realized I had to do scientific work because otherwise no one would believe me. They called it just a hobby, a stupid hobby to be interested in female cardiovascular health. So I had to to do really hard scientific work to show to the rest of the cardiology community, especially also in my country, that it was an important subject. So in the beginning, they thought I believed in fairy tales, that I was discriminating men and women. And, those boys, they told me, I don't discriminate. For me, women are equal. But now we know, 35 years later, we know that we have to discriminate because there is a difference. And if we don't make that difference, we misunderstand many of our patients. So in the beginning, it was a struggle to be believed for the upcoming science in this field. But, once I start working on the subject, I never stopped. And still, although I'm retired now officially from patient care, not from scientific work, but from patient care, I still give lectures, education programs, etc., because the next generation has to carry on and to move it further forward.
So just listening to you, I realized also that there was a point in the journey when you realized that it was no longer just a scientific question. There was also a cultural battle to change the culture, to look at women differently because of the sex differences. I think, what was the loneliest moment in that journey?
Well, I worked in a group with 15 male colleagues in a big non-university hospital. And in 2003, I decided to start with women-only outpatient clinics because at that time, I knew that men and women were different, but I wanted to know, why has one woman a high risk and the other one not? So women and women are also different. And this is why I wanted to start a special outpatient clinic for women. And I learned that in Canada, in the US, there were women's heart health outpatient clinics. And I wanted to do that also in Europe. And, my colleagues, they laughed at me. They said, well, if you think that's, reasonable to do, go ahead, and we will give you all our nasty female patients. We will give them to you. And I remember that the primary care physicians where I started, that they were not willing to send any patients. So I was there at the outpatient clinic seeing 2 patients a day. And that was the start. But, within a year, it was all full with women. So it took a while. It took a couple of months before, the patients came in, but it became a very big success. And even so, after, let's say, 10 years, it led to a professorship at a university hospital. And I realized that if you're lonely with the subject without any success, they don't care about you. But as soon as you're having success and a lot of attention, they don't like it anymore.
Yes.
But I think I should have also asked more colleagues to be involved. I should have invited them to have a look, to join me. Looking back, perhaps I was also a bit afraid that they would take it away from me because it was getting more and more successful. And then you're getting afraid that they want to take it away from you. So
Yes.
I think I could have done better if the environment were a bit more friendly.
Yeah. I mean, of course, hindsight is a beautiful thing. It's 2020 vision. But
Yeah.
but you've talked about that progression starting out with sort of 2 patients a day to
Yeah.
really having a success where you have lots
Yeah.
and lots of women. Now,
Yeah.
we know that lots of women have been told your heart is fine, even when it's not, for various reasons. I think I
Yeah.
want to talk about those blind spots that have led to, going from 2 patients a day to having so many
Yeah.
patients a day. What is the most common symptom that women describe that is still maybe underestimated or
Well,
misattributed
in,
today?
in, in fact, when women have ischemic heart disease, the pattern of ischemic heart disease is quite different in a broad range of age groups. So between 40 and 70 years, the standard in men is obstructive coronary artery disease, whereas we now know that in that age group in women, it's more spasm in the coronary arteries, it's more functional coronary disease. So that also means that you have symptoms of chest pain during exercise, but also at rest. That stress is an important trigger for symptoms, that women have more, other symptoms like nausea, extreme tiredness, also after a busy day. So women have more other symptoms together with the chest pain. And we used to call it atypical symptoms. But these symptoms, if you look at huge numbers of women together with having non-obstructive coronary disease, you see all the same kind of symptoms. So it's quite a characteristic range of symptoms that they have at middle age. Now we know how to identify women who are at high risk for having this functional non-obstructive coronary disease, because these are the women also, for instance, having had migraine since their teens, hypertension in pregnancy, several spontaneous missed pregnancies, spontaneous abortions, gestational hypertension, but also an early natural menopause or a lot of menopausal symptoms. So we now know how to identify the low and high risk women at middle age for this pattern of non-obstructive functional coronary disease. We have learned that over the past decades.
So you've talked about pregnancy actually sort of revealing the cardiovascular future
Yeah. Yeah.
of
Yeah.
women who could be high risk
Yeah.
or lower risk.
Yeah.
Why do you think it is that so many women, I mean, myself included, disconnect their pregnancy history from their later heart health? And why do clinicians do the same?
Yeah, well, it's also because when your pregnancy is over, your high blood pressure and all the things that can go wrong are also, behind you.
Yes.
But, it's a sign, it's a signal for a higher cardiovascular disease. We know that the risk for having hypertension at young age is about fourfold higher in women with hypertension pregnancies compared to normal pregnancies. We know that half of those women already have hypertension at the age of 40. And if you look at the prevention guidelines, there's no hypertensive pregnancy included because we're not used to look at that, because we are, as medical specialists, we are hidden in our silos. We look at cardiovascular symptoms, and gynecologists, obstetricians, they look at pregnancies. But the life course of women crosses several medical disciplines. And we have to learn to collaborate more with others because innovation is at the crossroad of different disciplines.
Yes.
And that's what we don't do sufficiently. So these are different fields of expertise. And if they don't collaborate, we're not bringing the subject any further.
Yes. That's an interesting point that you raise. I think it also ties into one of the things that we're seeing on the investments and capital side. And one of the trends that we're predicting, where we will see more investment and more capital going into women's health, is really at the intersection of verticals. So if we think, say, where cardiovascular health meets, say, hormonal health, or because it's a life journey. It's not silos.
That's right. That's right. It's a life journey. And we shouldn't look only from our different disciplines because that the patient is different, has a different life journey. So that's one of the most important things we have to change in medicine if we want to do it better in the future.
Talking about the life journey, I want to get your thoughts on another life transition that is super important for women, and that's sort of midlife health and menopause. Yeah. What is, in your view, I mean, you write about myocardial stiffness. So maybe we talk about that. How would you explain that to a midlife woman who feels unwell but doesn't have the language for it?
Yeah. Well, you know that when we're young, before menopause, our high estrogen levels are the most perfect vasodilators of our microvascular coronary system. So the flow in the microvessels is optimal as long as we're not entering menopause. But after menopause, when estrogen levels are quite low, you see that the small microvessels, we have millions of those microvessels, they're too small to have obstructions, but they're losing the vasodilating capacities that they used to have before menopause. So those tiny vessels, they stiffen. And that is translated into symptoms of dyspnea, shortness of breath, and specifically, when also blood pressure gets higher during menopause transition and the years afterwards, and also other risk factors like cholesterol gets higher, you see a more rapid stiffening of those microvessels. And if you look at women starting menopause at the age of 50, and you look at them 15 years later, they will have stiffened vessels and a loss of condition and a lot of symptoms. So that means that prevention of their risk factors needs to start early. We have to start at the beginning of menopause transition in looking at the risk factors and treating them when they're present. So we don't do that good enough. And for instance, high blood pressure is the most deadly risk factor in women worldwide. And we know that half of high blood pressure isn't recognized at all. And of the blood pressure that we see, only 20% is treated properly. So there's still a room for improvement to make aging more pleasant and healthy for women.
There's something you wrote about breast cancer treatments that I want to talk about with you as well, because that was fascinating. And we see that, breast cancer treatments, the chemotherapy and so on, that they're saving lives. Yeah. But you've also shown that they also leave women at risk for heart failure, say years down the line. Can you explain that to, listener who's hearing this for the first time? And also maybe we talk about why the oncology cardiology gap is still so wide.
Well, in fact, cardio-oncology is a booming subject on the big conferences, but the culture of oncology and cardiology in the hospitals, in the clinical field, is very different. Oncologists have learned to talk with patients, to discuss their fears and everything. And cardiologists, we are moving fast. We are always in a hurry. And we know that women being treated for breast cancer with a combination of radiation therapy and chemotherapy, and often infusion of trastuzumab afterwards, that those women, about 20%, they will have damage of the myocardium of the heart sooner or later. That can be during treatment, but also after 10, 15, even 20 years. And that's because the chemotherapy and radiation also damages the healthy tissue of the heart. And it's more outspoken when you're treated for a breast cancer on the left side because your heart is underneath. Yeah. So there are now new techniques also in radiation to lie a bit on the side, to bring the heart outside the radiation field, but also more tailored chemotherapy regimens to avoid toxic damage. But we need to be aware of that. And the kind of heart failure you can get from breast cancer treatment is different from the heart failure that you get from a myocardial infarction. It's more difficult to treat, for instance, the oncology damage. So it's very important, if it happens, to see it at an early stage, to be on time with your medical support. But it's a different kind of heart failure.
Yes.
And we need to learn that. We need to be alert on that. And we need to work closely with the oncologist, also in high-risk women. For instance, women being treated for breast cancer with very high blood pressure, those women are more prone to cardiovascular damage during treatment. This also accounts for women with lung cancer and radiation therapy if they still smoke. They have a higher risk for lung tissue damage. So there are a lot of things that we know and that we need to share with different disciplines to be aware of the risks that patients have.
Angela, if you could design sex-specific medical education from scratch, what would be the first 3 modules that you think this is what we should start
with? I think you have to start with the students, because the basis of medical education is at a student level. And if you will become a surgeon or a GP or a gynecologist, whatever, you have to learn, you have to be aware of the basis, what's different at basis. And then in different fields of expertise, you can extend the modules. You can learn how important it is to communicate with different disciplines and to invite other specialists to tell the latest news of what's happening, what we've learned. So it's a continuous education. And it's not about, giving women more attention than men, but it's about giving different attention to different patients. And this is also account for ethnic groups, for social cultural differences. In poor communities, the results of healthcare are also very different. And we can't stay within our outpatient clinics anymore without asking the appropriate questions about where patients live. If their household is healthy, if there is domestic violence, if there is poverty, how the food is. I mean, medicine is changing. We have to include the whole concept of living, the environment, into better healthcare. And that's different among men and women. Also, if you look at the damage of heating of the environment, the temperature is rising worldwide. And
Yes.
it has a worse impact on women, but also on elderly people, men and women.
Yes.
And we need to realize that, so to give more attention to those groups who need it most.
Yeah. Angela, you've been part of the European and global commissions. In your view, what is one policy change that would have the fastest impact on women's heart
Well, I
outcomes?
think an important issue is to put more women in the leading positions because women are natural more interested in women's health. They see more the differences. They also have a better view on what happens at home. And I think if, so many women work in healthcare, even much more women compared to men. But if we look
Yes.
at the leading positions, women are a minority. And this also accounts for ethnic groups, and the world is changing. So I think we need to have more women in leading positions who decide about what's important and what's less important. I think that will make a change in the end. That
And
will fasten our way of thinking differently.
yeah. And also for innovators, we speak a lot with innovators and investors. So for these groups of stakeholders, innovators and investors listening, where in your view is the most urgent unmet need? The place where, say, new diagnostics or tools could genuinely change outcomes?
I think women are very willing to collaborate with doctors in using tools, apps on the smartphone to identify when they are stressed or whatever. So it's quite easy to collaborate with women, but men are more often asked to collaborate with new developments. So don't be afraid to ask women and to ask elderly to participate, because I think in my whole career, I've
Mm.
learned the most from the female patients themselves, what they told me. And for instance, if you look at developments in pacemakers, a simple thing, if you put a pacemaker somewhere here and you have your bra every day over the pacemaker,
Yeah.
it hurts. It's not very nice. If
Yes.
you have an ICD somewhere there and you need to go for a mammogram,
Yeah.
you won't see the breast tissue properly. And
Yes.
women often don't show up because they're afraid that the ICD will get damaged. So they
Yeah.
just don't come. Also ask, how can we facilitate that you come to the hospital for cardiac rehab, for participation in clinical trials, because women are underrepresented. And it may be that women need transportation or otherwise a more convincing talk to participate in studies. And women have
Yes.
very good ideas also to how to implement changes at home. Women are creative people.
Absolutely. And we see this in the data. Top reasons for women not taking part in clinical trials
Yeah,
is really, as you say, I think number one is childcare. That was really the number
yeah,
one barrier.
yeah,
The
yeah,
second one was transportation, exactly as you said. So maybe we also need to be a bit creative
yeah,
in the design of clinical trials so that more women
yeah,
can actually
yeah.
take part.
Sure, sure. That's important. Yeah, yeah.
Yeah. Angela, after 35 years or more of pushing against the mainstream, what gives you hope now?
Oh, well, I think the new generation, the younger generation, is thinking more inclusive also about planetary health and health in hospitals, in outpatient clinics. They are more, they realize how important food is, how they're, I think they are less materialistic than perhaps my generation has been. We wanted to have, a big house, cars, and everything. But the younger generation, they want to have a bit more free time. They want to
Mm,
share experiences. They don't need to, I see it in my children. They don't need to have so much. They are more interested in what happens in the world, in safety for others, in collaboration. So I think give them the floor. It's
yes.
important also for you ask the opinion of younger doctors, the younger generation, how they look at healthcare. And I think the old cultural norms doesn't work anymore because they
Mm.
don't want to work like we did, and they shouldn't do it. I can't recommend them to do so.
Yes.
No.
I fully echo this.
Yeah. Yeah.
and and finally, Angela, what do you want, talking about the next generation, what do you want the next generation of cardiologists, especially say the young women who are entering the field, to take away from your journey?
Well, I think that sex and gender issues in the cardiovascular field are huge, and they should be part of the knowledge of every cardiologist, whether it's a man or a woman, it doesn't matter. So they should know all the basic important differences. And I think for those who are more interested, well, be part of a specialized clinic, work close together with gynecologists, menopause experts, even neurologists, because there's also a big difference, for instance, in strokes at young age in women compared to older age. And those
Mm,
differences are more prominent in women than in men. But also include the household issues, the combination working, having a family with or without a partner. There's so many women having a job and a family without having a partner. That's difficult to combine. So
mm,
those women may need more support to stay healthy and to be able to combine it all. Because households are different compared to 30, 40 years ago. They're more single households and, single moms and divorced parents. So we need to include that kind of living more in the way we
mm,
look at patients and the possibilities they have to come to a hospital. We need to do more remote controls. We can do it, but also the contribution at home of biofeedback, computer technology, etc. So it's getting slowly to introduce all those new devices because often there's no payment for that. And
mm.
if the payment doesn't go along with the new technical developments, doctors won't introduce it in clinical practice
Yes,
because they want to be paid. That's how the
yes,
culture is.
yes,
So that
yeah,
has to go together.
yes. Now, Angela, I think I could go on because I have lots of questions, but I think we will stop it here because our time has really come to an end. But when
Yeah.
I listen to your story and when I read your book and read about your journey, I think what stays with me is really the courage it takes to question a field from the inside, to stand in a room full of experts and say, I think we need to look at this again. And I
Yeah.
think, for me, your story really reminds us that medicine doesn't fail because we lack data. It fails when we refuse to see the people standing right in front of us.
That's right. Yes, that's a good summary. Thank you.
Thank you so much. Now, for
Okay.
everyone listening, if this episode made you rethink symptoms that you've dismissed, if it made you look back on your pregnancy, your menopause, your chest pain, or simply the way you move through the world, then please share it with someone who needs to hear it. You can find Angela's books. I bought it myself, A Woman's Heart, Why Female Heart Health Really Matters. And you can find her research and all her work. We're going to link it in the show notes. And you can follow Angela and her work, and you can follow all of our work on gender-specific innovation at Blindspot Capital and the Femme Health Alliance. Angela, thank you so much for
Thank
this
you,
episode
Maryann.
and for being here.